morning, good afternoon, or good evening, wherever you are, and welcome to another webinar in the LiDCO Hemodynamic Monitoring Series. My name is Shane Dorish, and I'll be hosting this event today. This event will discuss the impact of COVID-19 on ICU patients, their major organs, and the circulatory system, and how advanced monitoring of hemodynamics may help in their treatment. Before I introduce today's speaker, just a few comments on our webinar. This session will run for approximately 1 hour with a clinical presentation, and then we will take any questions raised during the presentation in our Q&A segment in the time that remains at the end. All attendees will remain on mute, so if you'd like to raise a point or submit a question during the webinar, please use the chat function, which you'll find on the right of your screen, or you can email me directly at shane.dorish@lidco.com, and you'll find that email address in the chat section. It should be the very first post at the top of the screen. The session will be recorded and posted on our LiDCO YouTube channel in due course. And for those of you who have submitted your email address, we will send a notification and a link. You can also subscribe to the LiDCO YouTube channel to receive notifications of new added content. So thanks in advance for your attention and engagement. I would now like to introduce our speaker for today, Dr. Frederic Michard. Originally from France, Dr. Michard trained in intensive care medicine in Paris, and then in anesthesia and critical care at the Mass General Hospital in Boston, United States. He is known for his research work on pulse pressure variation and fluid responsiveness, with more than 9,000 citations on Google Scholar and over 200,000 downloads from Biomed Central. He has given more than 500 invited lectures in 5 continents on heart-lung interactions, hemodynamic monitoring, perioperative fluid management, and more recently on digital innovations, mobile monitoring, smartphone medical applications, and wearable sensors. In 2016, he founded MiCo Consulting.com, a Swiss consulting and research firm focusing on monitoring innovations. More recently, he led a large global survey on hemodynamic monitoring and management in COVID-19 patients that is expected to be published later this year, and you may have seen some of that information and activity on social media of late. So without further ado, I would like to pass the controls over to Dr. Michard. And Frederic, if you come off mute, you're ready to go.
Thank you very much, Shane, for this kind introduction. And thank you for the invitation to be part of this webinar. So before maybe I should activate the camera. No, I can't do that from my computer. Anyway, I think you are more interested in the slides than in my face. So before I start discussing fluid management in COVID-19, I just like to acknowledge once again the fact that today I'm leading a consulting company based in what we call the Swiss Silicon Valley, and where we focus on digital innovations with medical applications. And as you mentioned, Shane, I mean, we also do research, and indeed we recently did a large survey that was actually published 2 days ago, focusing on the hemodynamic monitoring and management in COVID-19 patients, and I'm going to share some of the results with you during this presentation. So that was the count this morning. I mean, like me, you probably check from time to time, and so this morning, obviously, over 20 million cases of COVID-19 worldwide. Unfortunately, I mean, most people infected by the virus, or most people who test positive, are usually asymptomatic or develop mild symptoms, typically flu-like symptoms. But we all know that a subset of patients who are going to develop complication, and the most common complication is obviously a pneumonia, that may evolve towards an acute respiratory distress syndrome. And so many of these patients who develop the pneumonia will need to be hospitalized to receive oxygen, high flow oxygen very often. And some of them, actually many of them, will finally be intubated and spend a few weeks in the ICU. Patients may also develop acute circulatory failure, and so far there are very few studies focusing on cardiac complications or cardiovascular complications. I tried to summarize for you on that slide what we know today. So you see 4 studies reporting the percentage of patients who are receiving vasopressors. And you see it's ranging from 35% up to 94%. So obviously a very significant proportion of ICU patients with COVID-19 need vasopressor support, and we could use these treatment as a definition for acute circulatory failure. In the survey I just mentioned, we asked, one of the key questions was, do you use vasopressor in these patients? And you can see that the majority of the 1,000 intensivists and anesthesiologists who answered the survey said, yes, we use vasopressor either frequently or very frequently. So obviously, acute circulatory failure is not an exception. And so COVID-19 is not exclusively about the lungs. So why so many patients need vasopressors or develop shock or acute circulatory failure? Actually, when we think a minute about this sepsis, it's not really a surprise. A patient developing sepsis, first of all, may have vasodilation because of the systemic inflammation. Also because we give them sedative drugs when they are mechanically ventilated. And as I already mentioned, most COVID-19 patients admitted in the ICU actually need mechanical ventilation. Some patients may be hypovolemic as well. First of all, because very often they had fever during days before ICU admission, but also because fluid restriction is an habit for all patients who are admitted in the hospital at the beginning when they start to deteriorate and they need oxygen. Most clinicians are going actually to restrict fluid administration, because clearly the fear is that patients are going to develop pulmonary edema. So we try to minimize fluid input as much as we can. So because of that, patients may be or may become hypovolemic during their hospitalization. Some patients may also develop left ventricular systolic dysfunction. I would say like in any septic situation. Because of the circulating cytokines. So it could be a cytokine storm, it could be a small or a big storm, but they are clearly circulating cytokines. And we all know that they may have they may impact right and left systolic function. And myocarditis may obviously be a possibility as well. There are a few cases which have been reported in the literature. And last but not least, these patients may also develop right ventricular dysfunction. First of all, because, as I said already, they are most of the time mechanically ventilated and sometimes with high level of PEEP. And the second reason is that some of these patients develop pulmonary embolism. You know that thromboembolic complications are actually pretty frequent in these patients. At least we observe thromboembolic complications more often than in the general ICU population. So this is actually the only echo study I found so far published focusing on these patient population, COVID-19 patients. So these are not exclusively ICU patients. It's a mix of ICU patients and patients on the wards. And you see that this is a study that was published recently in the European Heart Journal, so done by cardiologists. And you see that the majority of these patients don't have a normal echo evaluation. They either display some left or right ventricular dysfunction, and sometimes it's both right and left ventricular dysfunction. We also have this research letter. It's a small evaluation published recently in Critical Care. You see a very small number of patients, 18 patients, but this one is done in ICU patients who are mechanically ventilated. And once again, you see that actually most of the time the echo evaluation is abnormal with either left ventricular dysfunction, right ventricular dysfunction, sometimes hypovolemia, and sometimes hyperkinetic states, which are obviously related to systemic vasodilation. So in the survey, here are the echo findings. So once again, it's a feedback from 1,000 intensivists, and you see that most of the time, obviously, there is a normal heart function, 53%, but it's also pretty common to observe an hyperkinetic state. It's not an exception to detect or observe hypovolemia, so we have to be careful. A fluid restriction obviously has limits, and as expected, because these patients have sepsis and these patients are mechanically ventilated and may develop pulmonary embolism, a significant proportion also of these patients develop left ventricular systolic dysfunction or right ventricular dilation. So I think it's very important at the very beginning to do an echo to clearly understand which phenotype it is, and then of course choose the most appropriate treatment. Some of these patients may develop as well acute kidney injury, and this is a very interesting review recently published in Intensive Care Medicine, where they pooled all studies published so far, where they count the number of acute kidney injury events. And you can see that when you pool all these studies together, the average percentage of patients who develop AKI ranges between 11 to 14%. So it's not huge, but it's a significant proportion of patients who develop acute kidney injury. The mechanism responsible for acute kidney injury are multiple. It's obviously pretty complex from a pathophysiological standpoint, but clearly fluid restriction and hemodynamic instability are going to play a role. And you may have seen that paper as well, recently published in the British Medical Journal. These are actually nice guidelines. So if you are from the UK, you are probably familiar with this publication, where they clearly disclose that AKI associated with COVID-19 may be caused by volume depletion. It's not the only mechanism responsible for AKI, but that's something at least we can act upon. So you already understood we are in a pretty challenging situation, because the temptation, as I said, in these hypoxemic patients, they need oxygen, they have arterial hypoxemia, they may evolve towards ARDS, they may develop ARDS, you may need to intubate these patients, so you try to minimize fluid input to decrease pulmonary edema, or at least to minimize the development of pulmonary edema. And your hope is to maintain arterial oxygen saturation within a reasonable range. But if you, at the same time, decrease cardiac preload and cardiac output, you may increase acute kidney injury. And actually, by decreasing cardiac output, you may decrease SVO2. And if your patient has a significant intrapulmonary shunt, the low SVO2 may contribute to the low SaO2. So it's a paradoxical effect on arterial oxygenation, and it's definitely not what you are looking for. So maybe you need to give some fluid, but not too much, because if you give some fluid, you will optimize cardiac output and probably decrease acute kidney injury. But of course, if you give too much fluid, you may worsen pulmonary edema, decrease arterial oxygen saturation, and precipitate tracheal intubation and mechanical ventilation. So that's a very challenging situation. Many intensivists actually are familiar with, because it's a typical situation of septic shock with ARDS. But in that case, I mean, COVID-19 is responsible for this situation. So clearly predicting fluid responsiveness may be extremely useful. First of all, to identify patients who may benefit from fluid administration, so patients who are fluid responsive with clinical and biological signs of shock. And maybe more importantly, to identify non-responder patients and then prevent unjustified fluid administration. Because if you know in advance that fluid administration will have no impact on hemodynamics, on global blood flow, it doesn't make any sense to take the risk to give fluid to these patients. So it's a way to individualize fluid management. And we already know that in surgical patients, individualized fluid management based on the prediction of fluid responsiveness is useful to improve postoperative outcome. This is a meta-analysis we published a few years ago, where we pooled all studies where clinicians used the prediction of fluid responsiveness during surgery, and we observed a 49% decrease in postoperative morbidity. Interestingly, there are recent studies, 2 studies published over the last 6 months, so in 2020, showing that also in ICU patients with sepsis, if for fluid therapy, for fluid management, we use dynamic variables or dynamic tests, we can improve outcome. So this is the first study. It's a multi-center prospective study done in South America. And this is the second one done in the US. And you see on that slide, I have focused specifically on acute kidney injury. You see that actually when clinicians were predicting fluid responsiveness, they were able, or at least it was associated with a significant decrease in the percentage of patients who required renal replacement therapy. So I is the intervention group, where they were predicting fluid responsiveness, and UC is the usual care group. In the survey, 84% of respondents said, yes, we predict fluid responsiveness. We heard the message. We know it's important and valuable. And it's actually in sharp contrast with this study published 5 years ago. So this is a paper probably many of you know, the FENIS study, done by a group of experts from the European Society of Intensive Care and published in Intensive Care Medicine. The study was published 5 years ago, but done 7 years ago, and then the conclusion was actually pretty negative. I mean, intensivists basically said, no, I mean, we heard about this concept, but we don't really use it on a daily basis. So obviously things have changed, at least according to the feedback we got for our survey. Let's focus now on practical aspect, because I think that's what you are clearly interested in. So first of all, for echocardiography, I mentioned it's very important to do an echo at least at the beginning to unmask what kind of phenotype you have to deal with. You can simply do a qualitative evaluation. You know that there are many studies, in particular from Etienne Biard-Baron from Paris, who have demonstrated that a qualitative evaluation is at least as good and, of course, much easier to perform than a quantitative evaluation for intensivists and in the ICU. So you can just look at the left ventricle, look at the right ventricle, look for a right ventricular dilation. You can also, of course, assess the volume status and look at the IVC variation or the VTI variations in patients who are mechanically ventilated. In case you are using TEE, you can use a superior vena cava variability. So there are different ways to predict fluid responsiveness using echo. And you can use pocket echo devices. As you know, I mean, there are more and more devices on the market, and it's pretty convenient to have one in your pocket. So clearly doing an echo is much easier than 20 years ago or 30 years ago when I was a resident and we had to bring the machine from the cardiology department. To predict fluid responsiveness, it's also much easier than in the past. First of all, there are different methods. Sometimes I believe it's maybe too much, and then people are a bit confused. So I'm going to try to summarize what can be done, and you will see it's pretty easy. First of all, of course, you can just look at variables like PPV, SVV, or PVI. So PVI is a place variability index. In theory, you could use it, but in these patients who are in the ICU with COVID-19, mechanically ventilated, they all have an airline, so it doesn't really make sense to look at PVI. You look at pulse pressure variation or stroke volume variation if you are monitoring cardiac output continuously. And we know these variables predict fluid responsiveness, but we also know that there are limitations. And one of these limitations is mechanical ventilation with a low tidal volume. And obviously in these patients with ARDS, you will use a low tidal volume, around 6 ml per kilogram. And so if PPV and SVV are high, of course, fluid responsiveness is very likely, but if PPV and SVV are low, you cannot conclude because it may be simply explained by the low tidal volume. So you need alternative solutions. And one of them is, and you know that already, the passive leg raise maneuver. You're going to mimic the effect of fluid administration, but without the need to give a single drop of fluid. And then if you can, during the maneuver, at the same time, detect changes in stroke volume or in cardiac output, or changes in PPV and SVV, then you can identify who are the responders and the non-responders. So this is a principle of the PLR maneuver. You are going to mobilize the blood from the legs and the abdomen to the chest and the heart. And then if your patient is fluid responder, you will observe during the PLR maneuver a significant increase in cardiac output. And so if you predict fluid responsiveness, or sorry, if you predict your patient is fluid responsive, and if your patient has clinical and biological signs of shock, then it makes sense to give fluid, and you should observe a significant rise in cardiac output during fluid administration. The beauty of the passive leg raising maneuver in this specific context, as I said, is that you don't need to give a single drop of fluid. It's completely reversible. Another way to predict fluid responsiveness is to use the end expiratory occlusion test. So you're going to stop mechanical ventilation for about 1 minute at the end of expiration. And like during the passive leg raising maneuver, if your patient is fluid responsive, you should observe a rise in stroke volume. So here you have the blood pressure waveform, but very often it's actually visible on the blood pressure. But in practice, what's recommended is to monitor stroke volume and cardiac output and to assess the changes during the end expiratory pause. And you see in this example that in this patient, during the pause, a significant rise in blood pressure, and then during the subsequent volume expansion, a significant increase in blood pressure that, of course, was related to a rise in blood flow. So once again, if you unmask or discover or observe a significant rise in stroke volume or blood pressure during the end expiratory occlusion test, you can predict your patient is fluid responsive. Another way to detect fluid responsiveness is if you perform recruitment maneuvers. So I know, some clinicians are using them. Other clinicians are a bit concerned by the hemodynamic risk of recruitment maneuvers. And indeed, because we increase airway pressure to a pretty significant level, very often we induce a significant drop in cardiac output, but only in fluid responder patients. So it's also a way to unmask or detect fluid responsive patients. That was nicely demonstrated by this study done by Mathieu B in a paper published years ago in anesthesiology. You see on the left-hand side, patients who experience a significant decrease in stroke volume during the lung recruitment maneuver. And on the right side of the slide, you have actually patients in whom we observed, or they observed, only a slight decrease in stroke volume. So on the left, you have actually the fluid responders, and on the right, the fluid non-responders. And in that study, the best cutoff value to discriminate between the two groups was around 30, and that was very convenient. And that was this, and that's the reason why now it is known as the 30 maneuver, because in practice, if you apply 30 centimeters of water, of airway pressure during 30 seconds, and you observe a drop in stroke volume which is less than 30%, then you can bet your patient, or you can predict your patient is not fluid responsive. And you see in this example, a small decrease in stroke volume during the recruitment maneuver, and then during the subsequent volume expansion, no change in stroke volume. Stroke volume index is here in blue. Here in contrast, the same 30 maneuver, so you apply again 30 centimeters of water for 30 seconds, and you see a dramatic decrease in stroke volume. Of course, you need to monitor stroke volume continuously. And in that case, it's much more than 30% drop. And then you can predict your patient is fluid responsive. And indeed, you see that when they gave fluid to that patient, they observe a continuous increase in stroke volume. So the lung recruitment maneuver some of you are using just to open the lungs are also very informative regarding the cardiovascular status. If you can monitor stroke volume at the same time and quantify the changes in stroke volume during the maneuver, you know if your patient is fluid responsive or not, which may help you, of course, to treat your patient if he's developing or she's developing signs of shock. Another one is a tidal volume challenge. So you may want simply to increase the tidal volume for, again, just about 1 minute from 6. Let's say you are starting from 6 ml per kilogram, which is pretty classic during protective mechanical ventilation strategies. Then you increase from 6 to 8 for about 1 minute. And then you can look at the changes in stroke volume, of course, but also at the changes in pulse pressure variation or stroke volume variation. And that was initially described in this critical care medicine study published by Sheila Miatra in collaboration with Xavier Manet and Jean-Louis Teboul. And what they nicely showed is that if you observe a significant rise in PPV, in pulse pressure variation, and you see by more than 3.5%, then you can predict your patient is fluid responsive. If, in contrast, PPV or SVV do not change during the tidal volume challenge, you can predict your patient is not fluid responsive. Last but not least, you can do a fluid challenge, but I would say a mini fluid challenge. You can simply administer 100 ml of fluid quickly and assess again the impact on stroke volume or on PPV and SVV. Then it's a way to predict fluid responsiveness. There are studies showing that if patients are responding to 100 ml, very likely they will respond to 250 or 500. So fluid responsiveness, I said it's easier today than in the past. Why? First of all, because I think we have more clarity regarding which tests may help and what are the cutoff value we can use to discriminate between responders and non-responders, but also because industry developed tools, and I want to share with you some examples. So there are now tools you can use on your hemodynamic monitors. Let's say you do a non-expiratory occlusion test, or you do a passive leg raise maneuver, and then you can ask the monitor to automatically calculate the delta stroke volume, the change in stroke volume. So if, for instance, in this example, there is no change in stroke volume, you see from baseline to the peak value during the passive leg raising maneuver, no change obviously in that case, you know your patient is not fluid responsive. If you do a lung recruitment maneuver, in contrast, you are going to detect or track the decrease in stroke volume, not the rise in stroke volume. During end expiratory occlusion test or passive leg raising maneuver, you are going to look for a rise in stroke volume. In contrast, during the lung recruitment maneuver, you are going to look for a decrease, a significant decrease in stroke volume by more than 30%. And in this example, again, no change. So this patient would be a fluid non-responder. If you do tidal volume challenge, I said the study published or studies published so far actually focused on PPV and SVV changes. You could actually look at stroke volume changes and cardiac output changes. But what has been published so far is about stroke volume variation and pulse pressure variation changes. And on that screen, you have the automatic calculation of the changes in PPV or the changes in SVV. And it's going to tell you again if your patient is fluid responsive or not. So in conclusion, many COVID-19 ICU patients develop acute circulatory failure, and some develop acute kidney injury, and both are related. It's not specific to COVID-19. Echocardiography is extremely useful, particularly at the beginning, to identify the phenotype, the pattern, the profile, the hemodynamic profile, and so you can decide what is the most logical treatment. It could be fluid in case of hypovolemia. The prediction of fluid responsiveness, I showed you there are studies now showing it not only makes sense, I would say, from a physiological standpoint, but it's also useful to improve outcome. Not specifically, we don't have yet studies done in COVID-19 patients, but I shared with you two recent studies and pretty big studies showing outcome benefit in patients with sepsis and septic shock. And it's part of the current guidelines. I just want to conclude with that. I don't know if you have seen this paper. These are actually the first recommendation published by the Asian Critical Care Clinical Trials Group. So of course, you know, they had to deal with the first cases in China. And so in Asia, I mean, they shared information and they published this beautiful paper in the Lancet Respiratory Medicine. Very early, I think it was published in February. And you see that they clearly mentioned check preload responsiveness. And then the surviving sepsis campaign guidelines were also quickly updated and published in critical care medicine and intensive care medicine. And they also clearly mention use dynamic parameters to assess fluid responsiveness. And last but not least, there are also guidelines from WHO, and they clearly mention consider dynamic indices of volume responsiveness to guide volume administration, because it makes sense, but also because now we have evidence that it may help to improve outcome. So with that, I thank you very much for your attention, and I'm very happy now to be part of the discussion. Thank you very much. If you have additional questions at the end of the session, feel free to shoot me an email. I'm always happy to continue the discussion. Thank you.
Thank you very much, Frederic. That was a very clear and well explained walk through the topic. Great presentation, and also well done on for sharing some of the information from a very informative and insightful global survey that you recently conducted and published. There's a couple or three questions coming through on the chat. If there's any further questions, feel free to submit them. I'll try and organize these in a little bit of an order to see. Okay, so this one maybe goes back to an earlier slide in your presentation. The question is, why do you think there is such a range in patients receiving vasopressors in your survey? So I think that goes back to maybe one of your earlier slides, which I think showed a range in vasopressor usage across different regions. I think you were showing.
Yeah, so the range is between 35% up to 95%. Actually, if you exclude the very first study from China, 35%, I think it was a small number of patients. If I remember, it was around 50 patients. It's more somewhere between 65 and 95%. So it means I think the take-home message is that the majority of COVID-19 ICU patients. Okay, I didn't say all patients in the hospital. Okay, but as soon as patients are in the ICU, obviously more than 50% of them have some degree of hemodynamic instability. And I think to answer this question, that it clearly depends how you define vasopressor support. I know there are studies where they actually consider only vasopressor support when you give more than 0.1 microgram per kilogram per hour of norepinephrine. Below, they consider it's kind of business as usual for patients who are receiving sedative drugs. So I already got this pushback of clinicians who said, yeah, but it doesn't count because it's a very small dosage. But I was reading this morning a new paper. Actually, it's not a paper. I was listening a webinar, and it's a study that should be published within the next few months by a French group. And it was like 67% receiving vasopressors. And if you just consider patients receiving over 0.1 microgram, it was 50%. So still, of course, obviously, some of these patients are receiving a very small dosage of vasopressor support. So it's maybe not a real hemodynamic instability. It may be simply related to the sedative drugs they are receiving to accept mechanical ventilation. But even when you exclude these situations, you still have around 50% of these patients who need vasopressor, a real and I would say strong vasopressor support. So there are studies currently going on in Europe, in the US. So I think in a few months from now, we will know a bit more. The survey we have done, it's a survey, okay? So it's not a prospective study where informations are collected. So in the future, I think we'll have, in a few months from now, we have real observational studies, and we will know more about the real hemodynamic status of these patients. With more echo information, more cardiac output measurements, there are studies going on, but they are not yet published.
Okay, thank you for that. A couple of questions here related to some of the assessments you'd mentioned regarding lung recruitment maneuver tidal volume. I think you may have touched on these during your presentation, but do no harm perhaps to go over it again. What time frames would you suggest holding for to expect to see the change with lung recruitment maneuver and tidal volume challenge?
So what has been proposed by Mathieu Biet for the lung recruitment maneuver, it's 30 seconds. And what's easy, as I said, it's to increase airway pressure up to 30 centimeters of water during 30 seconds, and then to assess the impact on stroke volume. So it's easy to remember. But of course, you know, you could do 20 seconds or you could do 40 seconds. It doesn't really matter. And for the other one, that was the tidal volume challenge. Doesn't matter. I mean, it could be between 30 seconds and 90 seconds. It's just to give you an idea and to ensure people understand it's something very short. So it's not going to be dangerous for patients, you know, to increase tidal volume from 6 to 8 for about a minute. But anyway, when you do it, I mean, I don't know. I'm sure some of the clinicians who are asking these questions tried already. I mean, it's almost immediate. You know, you do the end expiratory occlusion test, or you do the tidal volume challenge, or you do the lung recruitment maneuver. It's in a few seconds you observe the hemodynamic effect. The passive leg raise maneuver, it's a little bit longer. It's more about 90 seconds. I think that we usually reach the peak, but with respiratory maneuvers, in a few seconds, you usually observe the maximum hemodynamic effect. In practice, you know, on the monitor, anyway, the monitor that I showed is going to monitor everything continuously and is going to calculate the maximum or the minimum value depending on the maneuver. And so that's also, I think, the value of this continuous monitoring system is that you can be sure you're going to capture the nadir or the maximum value. And that's what you don't want to miss. And sometimes it's going to be after 15 seconds or 20 seconds. It doesn't really matter. I mean, if you do the maneuver for about 1 minute, you are sure you're going to capture these max and min values.
Okay, thank you. A related question, some of which I think you touched upon again. This is our final question, unless there's anything else from the floor. What are the perceived limitations or risks of these tests, and expiratory occlusion test, tidal volume challenge, lung recruitment maneuver, etc.? So related, I think you may have touched on some of those. That's our final question.
I'm not sure I understood your question, Shane. What are the risks?
Yeah, are there any limitations or risks of any of these tests? And then the list of end expiratory, tidal volume challenge, lung recruitment maneuver.
So as I mentioned during the lecture, I mean, the lung recruitment maneuver have been criticized because it's a significant increase and rise in airway pressure, and so they may induce a significant drop in stroke volume and cardiac output. So clearly, if your patient is very unstable, I think it's probably not a good idea to do lung recruitment maneuvers. And anyway, I think many clinicians have not really integrated this maneuver into their practice. And there are alternative options. The end expiratory occlusion test or the tidal volume challenge, I think it's basically no risk because what the changes you induce are very small. The threshold values, I did not insist on that, but when you do an end expiratory occlusion test, for example, you are looking for changes in stroke volume or cardiac output, which are more or less than 5%. And so it's not, I would say it's not risky.
Okay, well, that concludes the questions that we've had on chat and email. We're finished up early. Everyone will be able to enjoy their morning, afternoon, or evening. So I'd like to thank again our presenter, Dr. Frederic Michard, for a fantastic presentation. Oh, hang on, there's a few more. Okay, we've had one more question just popped up. If we are doing lung recruitment maneuvers on potential pulmonary edema patients, will there be any resistance in the lungs or playing with the lungs?
Sorry, what would happen to the lungs?
Would there be any resistance in this manipulation with pulmonary edema patients?
It's a good question because the study I mentioned from Mathieu Bier was done actually in surgical patients, so in patients with normal lungs. And so I don't have the answer. I mean, we would need to do a study to confirm the value of the lung recruitment maneuver in patients with pulmonary edema. I would say it's probably another reason to use the alternative test, so the tidal volume challenge or the end expiratory occlusion test, or simply a passive leg raise maneuver.
Okay.
The advantage, the only advantage of the lung recruitment maneuver is that it's inducing a dramatic change in stroke volume and cardiac output, so it's easy to detect. That was the value. But of course, the downside is that it's a bit more risky. And of course, also, as highlighted by the person who asked you the question, I mean, we are not sure it works in patients who have ARDS, and that would deserve to be confirmed by a clinical study. It's a very good point.
Okay. Okay, well, that concludes the questions that I mentioned. Again, thank you, Frederic, for taking the questions, going through a great presentation. As I've mentioned earlier, we will post the video of the webinar on our LiDCO YouTube channel. You can also visit our lidco.com website to assess some of the blogs that we have on related clinical subjects. Thanks again to everyone for your participation and engagement, your questions. And I'd like to thank you once more, Frederic, as we conclude the webinar.
Thank you very much. Thank you very much. And if some of the attendees have additional questions, I mean, they can contact me by email.
Absolutely. Okay. Thanks again, everyone. And keep an eye on your email for future upcoming webinars. Take care now. Thank you.